Hello, this is Alisa Kim. I'm a PGY1. I'll be doing a journal article presentation on CT screening and lung cancer outcome. This is a 2007 JAMA article that I was able to read on CT screening. This came out before the actual guideline by the government on the annual CT screening for smokers. So the background information, at this time of the journal article in 2007, lung cancer accounted for 20 to 25% of cancer deaths in Italy and US. Because of this, and it is related to smoking, as smoking is the most common reason for lung cancer development, screening for individuals at high risk for lung cancer to see if it will reduce cancer deaths related to lung cancer could be done via routine screening was the question asked by this article. According to this journal article, there were randomized studies of lung cancer screening with chest x-rays were completed in the past. However, the article showed no support. They showed that chest x-rays increase identification of lung nodules, however, did not reduce the likelihood that individuals would be diagnosed with new cases of advanced lung cancer or would die of lung cancer. So the question asked by the journal or the researchers was, would CT screening for lung cancer be effective in screening for reducing lung cancer related deaths, as well as diagnosing advanced lung cancer cases? So the study design and method is that this article is a single-arm clinical trial, which means that it only has an interventional group. There is no control group per se, and it does not have any randomization or blinding. What the researchers did with the study was they compare their own results to prediction results that were predetermined using two models that were developed to estimate an individual's level of risk of either being diagnosed with lung cancer or dying of lung cancer. The estimation was also multiplied by the conditional probability of these events based on their age and sex matched individuals in the National Cancer Institute's database. The models were designed to apply to high-risk individuals, such as age 50 to 80. The individuals should have smoked between 25 to 60 years, average between 10 to 60 cigarettes per day. If the individual had quit smoking, they should have quit within the past 20 years. The individuals or the participants within the study were individuals who had to have smoking history or no prior history or symptoms suggestive of lung cancer. They were enrolled in one of three centers, one in Italy and two in the US, through advertisements, direct mail, and local physician outreach. Of these participants, because of the model required age 50 to 80 and the smoking history, some of the participants were excluded. And the study went on for an average of 2.9 years post their initial CT screening. And they offered subsequent 3 or 4 subsequent annual CT scans to determine if the participants will develop or will be diagnosed with lung cancer in the future. When nodules were detected, the participants were evaluated using a systematic approach with follow-up imaging and biopsy. And the study was approved by IRB. and written informed consent were obtained previously. Outcome measures, there were 4 outcome measures from this study. One was number of individuals diagnosed with lung cancer. Second one was number of first surgical resections of lung cancer. Third was number of individuals whose first lung cancer diagnosis was of advanced stage, either stage 3 or 4, or any of the small cell lung cancer. And fourth one was number of individuals who die from lung cancer. And this data was collected through dates and cause of death, ascertained through medial record review in Italy, or according to the National Death Index assignment in the US. If status could not be reliably checked through public data resources about their death or the reason for their death, then this participant was eliminated from mortality analysis, which was 1 from the Italy and 7 from the Mayo Clinic and 22 in Moffitt Cancer Center. Clinical endpoints, these are some of the parameters in the study. The baseline or the initial start date for this study was date of first CT screening. And time of lung cancer diagnosis was equal to date of lung cancer in diagnostic pathology report, or date of death who died from lung cancer without a known diagnosis. Date of tissue diagnosis served as the start time for the survival analysis or the mortality analysis. Mortality endpoint evaluated commencing 1 year after the first CT scan through death due to lung cancer or other reasons. If it was because if the data before 1 year was included, it may result in false positive, as if the CT scan immediately resulted in death reduction. They also noted that there was an increase in number of people lost to follow-up in later years, and I will talk about that later in my bias section. Statistical analysis that were used in the study were chi-squared tests to find relationship between categorical variables, confidence interval of 95%, p-value less than 0.05 reported as statistical significance, and it was performed on Stata version 9.0. These are some of the characteristics of the participants of the study. As you can see that the age was around 60 and smoking history was around 40 years. And the quit year is around 7, averaging about 7 years. The critical endpoints shown here, the 4 categories or the 4 outcomes that the researchers were measuring are diagnosed with lung cancer, which was 144 in total, diagnosed with advanced lung cancer, which is 42 out of the 144. Lung cancer resection is 109, and mortality endpoint, which means lung cancer deaths, which were 38. As you can see in the mortality endpoint, it's not the same as the sample size. It is a little bit less due to the loss to follow-up, as well as elimination of deaths that were not recorded in the public resources or sources. These are some graphs that compares between the observed and the predicted results. As you can see, the lung cancer diagnosis for the observed is much greater than what was predicted, as well as the lung cancer surgical resections, which would make sense and correlate with increase in lung cancer diagnosis. What is interesting is that the advanced lung cancer diagnosis that was observed was very similar to what was predicted, as well as lung cancer deaths were very similar between 2 groups as well. As you can see in this table, These compare the predicted and observed value between lung cancer diagnosis, surgical resections, advanced lung cancer diagnosis, and lung cancer deaths among all the 3 centers. And this shows by the year when they were following up with the participants. What I noticed was that advanced lung cancer diagnosis did not usually decrease. There was no consistent decrease in advanced lung cancer diagnosis as the year went on. This is another figure showing the lung cancer diagnosis in total, as well as lung cancer surgical resection. And there is a big difference between predicted and observed. This shows the different types of lung cancers that were diagnosed. As we could make a guess, the participants who were diagnosed with lung cancer were at a lower stage. Most of them were diagnosed in stage 1 or 2. Those people who were diagnosed with stage 3 and 4, they were at a higher risk of having cancer-related, lung cancer-related deaths, as you can see in about 2-year survival of 47%. So the results, as in summary, is that number of individuals diagnosed with lung cancer was much greater in CT group than predicted, with absolute risk reduction of about 3.2%. Number of individuals who underwent lung cancer surgeries was also much greater in CT group than predicted, with relative risk reduction of 10. Absolute risk reduction was about 3% as well. Number of individuals diagnosed with advanced lung cancer in CT group was no different from the prediction number. And number of individuals who die from lung cancer in CT group was also no different from the predicted number. However, as I stated before, lung cancer death was coming most from the advanced lung cancer cases. And in the study, they also mentioned better survival rate in their participants compared to published survival rate, even in advanced stages. I believe that is more due to the small sample size. There were only 20 people compared to when you do the published survival rates, there'll be thousands of people. So interpretation. For the increase in lung cancer diagnosis, there is a question of whether this early lung cancer that we diagnose would not progress rapidly to a point of clinical detection, thus unlikely to contribute to meaningful share of all death from lung cancer, because there is an increase in lung cancer diagnosis. However, there is no increase in advanced lung cancer cases. So the researchers were saying it could be because the nodules that we're finding is not going to progress so rapidly to cause death. Or it could also be that lung cancer that were found would have progressed if given enough time, and the study wasn't followed for longer than 4 or 5 years. Increase in lung cancer surgeries was also noted, and they stated it as one of the potential public health consequences of CT screening, because with increase in lung cancer diagnosis, there would be a correlation of increase in lung cancer surgeries, which would make sense. However, would this occur when there was no CT screening? The prediction model shows that it wouldn't have. There would be a lower than what we would have observed if there was no CT screening. Despite routine screening, most of the lung cancers that were ultimately fatal were not detected until at an advanced stage or had caused a death. So for my critique, this study is a small sample size study that is a single arm. It does not have much of a control group per se that is similar to the intervention group. And in my opinion, they are comparing between a sample group and a population group. When they do the prediction model, they applied through the database, they made a model. However, they also applied the population database, which may not reflect the sample group, although sample group should be more reflective of the population group. But there is a dichotomy there, not much of a congruency. So they could have of different characteristics. Also, for the inclusion criteria for the participants, they had to have been asymptomatic, so not have any lung cancer symptoms. However, for the prediction model, that inclusion criteria could not be applied because it is more of a database. Some of the biases that I worry that were included in the study were confirmation bias, which means that the researchers or even the radiologists would have tendency to look for information or nodules because they already know that the participants have smoking history and they are getting screened for lung cancer or lung nodules. So that is a bias or possible bias. Another possible bias is a diagnostic bias. So with increase in lung nodules or lung cancers that are seen on the CT, there would be a lower threshold to get repeat imaging and biopsy. Would that have been done if there were nodules or if we didn't do a CT screening? That is also a question and something to keep in mind. Another one is a selection bias. So with the people who were lost to follow-up or people who were not included in the database that were lost to follow-up, depending on their characteristics, whether they were asymptomatic and did not have any diagnosis of lung nodules, or if they were sick and they had lung cancer, and depending on what kind of lung cancer, the data would have changed depending on their characteristics. So there is a selection bias when they excluded the people who were lost to follow-up or were not included in the public source. The last one is they followed the participants up to averaging about 4 years, up to 4 or 5 years, doing annual CT scans. This could be considered a short follow-up, and if the lung nodules were slow to progress, as the researchers were reporting in the study, they would need longer follow-up, 10 years or more, to determine whether this lung nodule would have become more of an advanced cancers or cause lung cancer related deaths. So from this clinical trial or study, now we actually have a U.S. Preventative Service Task Force recommendation regarding lung cancer. As providers, we are recommended to give annual low-dose CT screening for lung cancer in patients who are heavy smokers, 30 pack per year history, and current smoker or quit within the last 15 years, and ages between 55 and 80. And this was actually based on another study that was actually a randomized control study that looked between a CT scan as well as chest x-ray. And that showed a relative risk reduction of 20%. So that was where the recommendation came from. And here are my references.
Okay, Thank you, Dr. Kim. So this is Dr. Connell. I'm here with Dr. Kim and Dr. Justin Chronister in our illustrious recording studio at the Houston Center Clinic. So just a couple of comments from a statistical point, most of which Dr. Kim already has hit on, that I'm just going to re-emphasize. You know, the fact that this was a single arm study is a major weakness, because your control arm is your modeling study, which, as we all know from the current COVID-19 crisis, that modeling studies are only as good as the assumptions that you put into them. Now, could you argue that their modeling studies were probably accurate? Absolutely. But that is something that if you're looking at a single arm study and you're going to make clinical decisions off of it, you need to be very critical of what their control is. And if their control is a model, you want to know what assumptions do they put into that. And then really question, do those assumptions fit with what I see in the real world? So I think, you know, you made a good point there. And then there's obviously biases. So I think, you know, one of the major biases here is their length time bias. You didn't put it in those words, but that's what it is they had short follow-up. So would those nodules have become clinically relevant cancer? Don't know. One, because my control arm is a modeling study, and then two, I didn't follow them long enough to be able to say that, and you have that bias. The diagnostic bias is definitely there. I think the way you can think around, how could they have gotten around these biases? Length time bias, they could have lengthened it out. And then we've had studies since then that have had better control arms that we've looked at, that you referenced. Diagnostic bias, you know, having a blinded radiologist, which they looked at, and that changed the diagnostics, right? Like, because a physician may looked at one group, said there were more likely nodules, where a radiologist was less likely to call that. So those are just some things when you look at studies, especially studies like this, and diagnostic bias. Did they use a blinded diagnostician, or did they not? Why or why not, etc. So yeah, those are my kind of summary points on the statistics analysis of this particular study. I'll hand it over to Dr. Conster.
And I think from a clinical perspective, I think most of what I would want to talk about has been discussed. I think this study was done in 2007, or it was published in 2007 by JAMA. Did not move the needle tremendously in terms of what the recommendations have been. That was the study that Dr. Kim alluded to, called the National Lung Screening Trial, that was done in 2011, published in New England Journal of Medicine. For this study, it laid the groundwork effectively for what the NLCT study in 2011 did, which was add a second arm, which was a control arm, and randomized it through about 56,000 people. That study was our landmark study that did show the 20% reduction mortality with a low-dose CT scan compared to chest X-ray. So if we start looking at recommendations now, the recommendations from the United States Preventive Service Task Force for lung screening or lung cancer screening was done in 2013. A lot of discussion around that, which we can do in another journal club, revolved around, is this worthwhile? Before the study in 2011, the USPSTF was a little schizophrenic in terms of what their recommendations were. They went from recommending no screening to recommending screening, recommending no screening, now finally recommending screening again. The 2011 article, big study, randomized control, showed significant benefit to the point of having to stop the study early. The interesting thing that came out of that to me, though, is that the number needed to treat to save one life with low-dose CT screening was about 320. Generally, if you compare what the recommendations are, so someone with the ages of 55 to 80, 30-pack year smoking history, current smoker, or has quit in the last 15 years, that's about 7 or 8 million people in the United States. If you add the NNT of 320 to that, you're going to save about 8,000 lives, and it's going to cost about $2 billion to save those lives, so about $240,000 per person. So you start having a lot of people now who say, well, is this worthwhile? And I think that's debatable. We have new recommendations from the USPSTF that are in progress or in process now, because a lot of people American Academy of Family Practitioners, others have thought through this and said, well, we have less smokers in this country. We have less older smokers. We have less people that will start to meet this criteria. And will that affect the recommendations on any level? And so there are some that are looking at alternative diagnostic criteria for people who are at highest risk, where these models of low dose screening are best utilized. And so different studies looking at prostate, lung, colorectal, and ovarian cancer screening tool, which was done in 2012. We've got groups like the AAFP who say people who meet 1.3% or 1.5% 6-year risk of cancer in that population, that would be a better cohort of people to study. So long story short, this study was interesting because it creates a new type of study that we've not looked at really in Journal Club so far. Didn't move the needle tremendously in terms of what we do clinically. I do think recommendations moving forward will be less about pack year and age and more about a more comprehensive cancer risk assessment tool. I think that's what we'll start to see. And we also don't know what screening with low dose CT scans do long term in terms of cancer risk. So just so that everyone knows, a low dose screening CT is about 20 to 25% the radiation of a full dose CT scan. And so there's different groups that have looked at that and think that your risk of cancer, solid and heme, is anywhere from 3 to 4 multiples from someone who doesn't get that. So does that affect people clinically? I don't think we know that yet. These screening recommendations have only been 7 years old. So a lot that goes into it, but this study was a foundational study that led to current guidelines. Again, I think as physicians do a poor job following guidelines. A recent study back in 2019 demonstrated that only about 12.5% of people who met screening guidelines actually get screened annually. So I think that's something else to think about. Is that because we don't think about it, or is that because we're incredibly amazing doctors and we think that the recommendations are bunk? I think probably the former. So lot to take in. It's a great study to talk about. Really well done by Dr. Kim, and we appreciate you guys listening.